We are live now, doctor.
You. Okay. Good evening, respected seniors, colleagues, and all the wonderful and dynamic residents who have logged in today. I am Dr. Vaishali Agarwal, Scientific Committee Chairman, Rajasthan Ophthalmological Society, and it gives me immense pleasure to welcome you all for yet another masterclass of the online PG teaching program, Kaksha. Kaksha is a PG teaching program conducted by ROS for the past 1 year now, which will cover all the major topics of the current curriculum of PG teaching. We will be bringing the best of national and state faculty experts to share their knowledge and interact with you freely. The residents who have logged in are also encouraged to put forward their doubts in a fearless manner. As usual, the highlight is a quiz for you all kept at the end of the class with lots of prizes to be won. So keep a strong vigil and stay glued to the class. Coming to this class, we have today with us Dr. Vaishali Vasavada from Jaipur to teach us about the finer nuances of the most common intraocular surgery performed, that is phacoemulsification, and how to perform it safely. And it is a very important topic, not just for the postgraduates, but also for all the practicing ophthalmologists, especially the young budding ones out there. Just a brief about Dr. Vaishali. She is the director of Raghudeep Eye Hospital, Jaipur and Ahmedabad. She is a well-known authority in complex cataract surgery and pediatric cataract surgery, not just in India, but also worldwide. Has won numerous awards at the most prestigious international forums. She has numerous peer-reviewed publications and has a special interest in clinical research related to cataracts. I welcome the ROS President Sanjeev Desai sir, President-elect Sir Dr. Virendra Agarwal, and our Dynamic Secretary Dr. Ghulam Ali Kamdar from Jodhpur, your moderator for the evening. Today's hot seat residents are Aditi and Rishabh. Are you there, Aditi and Rishabh?
Yes, sir.
Okay. Vaishali, they will be the hot seat students. You can interact with them, and everybody else also can join in the discussion. These two residents are from SMS Jaipur. Over to you, Vaishali. You can upload your presentation and start.
So, very good evening to all, and I really appreciate and I want to thank the entire ROS and this great initiative, Dr. Vishal Agarwal, and then Dr. Sanjeev Desai sir, Dr. Ghulam Ali Kamdar sir, and Dr. Virendra Agarwal sir. I really feel privileged to be part of this Kaksha series on its, and I understand it is the 28th episode. I'll try my level best so that we make it clinically relevant for everybody, whether you are a beginner surgeon or you are already advanced into surgery or learning the hangs of surgery. And I would encourage all of you to put in questions in the chat at any point or any suggestions where you feel, I think I do this differently. And without much ado, let me get started. So I want to talk about the basics of techniques of phacoemulsification. And I think there are 3 or 4 broad headings in which we can take this. The first thing is to understand your phaco machine. Because until you understand the technology, whatever you have access to, you really can't get the best out of it in terms of outcomes or in terms of performance. The second important thing is understanding in general how lens fragment removal works in phacoemulsification, and then understanding the cortex removal. I want to start with a few really basic slides, but which I think even today in my practice are very, very helpful. And I try to remind myself of these caveats before I start or plan a surgery, and which is in the pre-operative time. I think the most important thing for any surgeon for performing any kind of surgery is respecting the eye, respecting any tissue, because if you don't respect the tissue, it is going to show up in the post-operative period. And the equally other important thing is to know that you will have complications and respect the fact that every surgeon has to face complications, but you should be aware of these and how would you then handle it. The good news is that thousands of us have learned phaco, and it's not something you cannot acquire. And now we have so many simulators, wet labs, and videos and all kinds of practice models that help you pick up much faster than what it used to be. So I think the phases of phaco or any cataract surgery, number one would be the right patient selection. Now, particularly when you are a beginner surgeon, you want to be very, very careful of what kind of patient you select. And in the pre-operative assessment, you don't miss out anything, including the doing a specular reflection. Look at the endothelium. And all of us have learned the specular reflection technique, 45 degrees angulation, and look at the endothelium if you see any guttata or any irregularities. Plan the kind of anesthesia. So I know that it's a big thing in the patient's mind, in the surgeon's mind, to have a topical anesthesia or just a drop anesthesia. But I think when you're beginning, there is no shame or there's nothing wrong it as a beginner or as an advanced surgeon. If you feel that this is not the patient who will be able to cooperate or who has a very deep set globe, don't hesitate to give a peribulbar anesthesia. And as far as possible, always have your anesthetist around so that they can manage any anxiety that the patient might be having related to cataract surgery. And then, of course, the steps of surgery is something all of us understand. Now, what I do want to bring out in the pre-operative evaluation is to talk to the patient and to look at the patient's general body habitus. Do they have a short, stocky neck? Do they have some kind of back abnormalities? Are they obese or are they heavy breathers? Do they have bobbing tremors of the neck or any kind of special assistance that they will need? And most importantly, they need to be able to lie flat for some time. So when I was in my beginning days, and sometimes even now with patients who say that we are claustrophobic or that I have a breathing difficulty, I cannot lie down, we make it a point that they are made to lie down on a cot in the hospital setting so that they get used to the hospital setting. And we call them one day prior, or if not possible, at least on the same day, 2 or 3 hours before the surgery, make them lie down for good 15-20 minutes and just see how they behave. So here I just took this example of a video where you see that this is a patient with chronic obstructive pulmonary disease and is a very heavy breather. And this is something, if you don't anticipate and if this keeps happening, this puts you off mentally. Once you are anxious or you yourself lose a little confidence, then things can spiral downwards. So anticipate and accordingly take measures, give them a nebulizer if they need outside the OT, or you be prepared that I will handle this. I'll just use 2 instruments to stabilize the globe and go ahead in my normal usual fashion. The other thing I would caution against for somebody who is just starting or in your residency or in your fellowship days, this is not the patient you really want to start with. While you can do it, but this is not the ideal environment, this kind of a very deep set orbit. And if you're not comfortable, please go ahead and plan an SICS or an ECC in such patients. I'm sure if you talk to the patient, the patient and the family will understand and in fact appreciate that you are trying to reduce the possibility of any intraoperative complications. So while all this sounds very basic, I have found myself many times trapped where you waited, there was a heavy OPD and you put in 2 dilating drops and within half an hour you see the patient didn't dilate well. But on the day of surgery, when the patient is fully dilated, you can come up or you can be surprised by these findings such as pseudo exfoliation, sometimes a very mild degree of subluxation, which would not be visible with let's say a 5 or a 5.5 mm pupil. So my message here is that always make sure that you wait for maximum possible pupillary dilatation before you plan the surgery. Another big challenge that is now coming up, we all are familiar and sometimes are better at doing white cataracts, very hard cataracts, but these kind of soft cataracts, younger patients, we see more and more of younger patients, steroid cataracts, posterior subcapsular cataracts. So these are ones which will also need a different surgical strategy. So beware of these cataracts as well as the extreme brown and brunescent. So for example, this cataract, maybe I can do it as a phaco surgeon and I want to prove to my ego that I am able to do it. But I don't think there's anything wrong if you plan an SIC. A well-done SICS in such a case will sometimes be a much safer option. So the whole idea is to plan the surgery. Now we move on to the actual steps. The first thing, let me come back again, is when you make the incision, the most crucial thing is the clear corneal incision. You may be doing a scleral incision or you can say superior temporal, but whatever it is, the plane of the incision, rather than being oriented downwards vertically, should be oriented horizontally. And we see. So this is not the plane you should enter in, because you can actually cause a touch to the anterior capsule, even if it's your side port knife. Instead, what I would recommend is going clear corneal and doing a single plane incision. Now, because things have improved so much, most of us now operate with 2.8 or 2.6 or 2.2 millimeter incisions. I would strongly recommend using a limbal or a clear corneal incision. You don't need to do a peritomy and a scleral groove most of the times in a phaco, unless you are dealing with a very complicated situation where you are not sure whether you will convert or not. So I like, and I strongly recommend for everybody, a clear corneal incision. Now here I wanted to show, this is a very slow motion. This is recorded at 200 times slower speed than the normal. What I want to show is how you make the clear corneal incision. So a disposable keratome or a diamond knife is taken, and at the limbus, you make the entry, and your hand is flush to the sclera. If this is the sclera, it is flush, and it just goes in one motion, and we'll see how that happens. So again, intentionally, this has been slowed down just to see every movement of, we are not doing a two plane. This is not a movement and then dip. This is going to be a continuous movement of your keratome. And you see that it's a little posterior limbal. It's not really very clear corneal. And very smoothly the knife will go in. Now here again, I think if you are in an institute or in a setup where everything may not be under your control, but as residents, what you can do, and what I used to do in my residency all the time, we used to buy these knives for ourselves, and I would take the autoclaved, I mean the sterile knife into the OT, where I would tell the nurse to open this in my case, so that in the beginning, I don't want to lose my confidence just because I had to struggle so much with a blunt knife to enter the eye. And then that ragged incision causes so many other problems. So I think for residents, for PGs, it's not a bad idea to invest in some of your instruments, and particularly in having disposable knives. I don't say you use one for each case, but you can at least definitely use them for 2 to 3 cases and not more than that. And while doing this, while making any kind of incision, whether it's a side port or whether it's a main port, it's also very important to stabilize the globe with a forceps or a spatula, a second instrument. And let me go back to this video. So what I again want to highlight is the direction in which the knife comes out. So you will notice here that when it comes out, it sort of splices obliquely. So this will not be a very self-sealing incision. So every little step, even that 2.2 millimeter incision, has a great value, and therefore use an instrument to hold the globe with your other hand so that you are comfortable in what you are doing. Even if the patient is under peribulbar, their eyes may be uprolled. Now the next step, rexis, and I'll just touch upon incision and rexis before we actually move on to the crux of the evening, which is how would perform an effective phaco. Now here, I prefer a cystotome even today, but you could use a cystotome or a forceps. What I do want to caution in your beginning days, cystotome is a little easier to control. One, it is cheaper. You just get a 26 gauge needle and bend it. How I like to bend is, if this is the hub, I like to bend it at the junction of 1/3 and 2/3. And the bend is not exactly 90 degrees. It is just short of 90 degrees. So that is the kind of cystotome I would prefer. And the aim is to have at least 4 millimeters of rexis. Now, SICS and phaco are a little different in the way that in phaco, you want a smallish rexis. You don't want too small, but you want a good cover on the IOL optic. And therefore, ideal is about a 5 millimeter rexis. It is not possible to have this kind of a rexis time in and time again, but aim for something that is more than 4 millimeters. Always use good viscoelastic. Now, sodium hyaluronate would be my choice for doing a rexis, because it is very cohesive. It is like a bolus, which will maintain space. Let's say you don't have access to sodium hyaluronate. That's absolutely fine. You can use methyl cellulose. But what I would, in this case, recommend, use a smaller incision. So use a 1 or 1.1 millimeter incision to guide your cystotome, so that the viscoelastic doesn't keep leaking, because methyl cellulose is not very retentive. it is a sort of a dispersive viscoelastic, so it disperses. It's not very good at forming space and maintaining the space. So you can always refill, but most importantly, make a small incision through which your cystotome can go. Don't press on the posterior lip of the incision, and make small movements of the flap while you perform your rexis. And so that is something I did want to highlight. Now, I have a question to which I think Aditi or Rishabh, whoever would want to answer. What is your preferred method for performing a rexis? Do you use a side port or main port, number one? And is it a cystotome or a forceps?
Usually we do from the main port because we use here sodium hyaluronate. So first incision is by cystotome for me, and then we use forceps to complete the rexis.
Okay. And how about you, Aditi? Is this the same with you as well?
Good evening, ma'am. Ma'am, yes, the initial flap elevation is done with the cystotome, and further I use a cystotome to continue with my 5.5 millimeter rexis, ma'am. I don't use a forceps, ma'am.
Correct. So I think this was a very important point highlighted, that your own preference, it really boils down to what you are comfortable with. But in the beginning, I would say a cystotome may give you more control. And there is a difference in the movement when you use a cystotome or you use a forceps. Very simply speaking, shearing versus shearing and tearing. With a forceps, you have to pull. You have to do, whereas with a cystotome, you are just tearing. It's like tearing apart, whereas with the forceps, you need to grasp it and then a shearing force of pulling it around. Now, in using forceps, I mean, you guys are lucky that you are using sodium hyaluronate, and that doesn't give too much issue. But if you are using the main port and you are using a big Utrata forceps, which goes through a 2.2 millimeter, and if you're using methyl cellulose, there is possibility that between the jaws of that forceps, the methyl will leak out. So like I said, either use a cystotome with a small incision like a side port or 1.1 millimeter incision, or keep topping up methyl cellulose so that you don't end up in unintended extension of your rexis if the methyl leaks out. So that is, I think, a very important point. Thank you, Aditi and Rishabh. And that's the beauty of being surgeons, that we all do well with our own techniques and our own approaches, provided we understand them well. Now, again, just I think a small bit on hydrodissection. That I like to use a 27 gauge cannula, and I don't tent my capsule so much. I usually go a little beyond the rexis margin, and then the endpoint obviously is a single fluid wave. But every time you will not have a fluid wave, in which case, don't worry, pass 2 or 3 small aliquots of hydrodissection and always decompress. Now, hydrodissection, I think 2 contraindications for hydrodissection. One is the white cataract. Whenever I see the patient with a white cataract, because I don't know what is a posterior capsule. This could be a posterior polar cataract. It could be a trauma where the capsule is already ruptured. So in a white cataract, I usually do not perform hydrodissection. I directly perform nucleus division, and then I will try and rotate and then perform a hydrodissection if needed. The other is a posterior polar cataract, where of course we all understand that doing hydrodissection can be lethal because you can cause a rupture in the already weak posterior capsule. So yeah, hydrodissection, while important, again, there is a caveat in very, very dense or white cataracts where you don't know what's the status of the capsule. So avoid doing. I have myself as a resident done this. In a white cataract, I performed a very good hydrodissection and the nucleus immediately dropped and I couldn't do anything. This was in my first year of residency. So I think that was the day I learned this hard lesson, that I don't want to hydrodissect when I don't know the posterior capsule status. Now I think we move on to the main crux of what I want to talk about today, which is your techniques and machine parameters for a safe and effective surgery time after time. And I don't mind stopping if there are any questions or suggestions or anything that any of you have. If not, we move on. So understanding the phaco machine. I think what we need to understand, basically the phaco has 2 parts. One is the lens fragmentation, dividing the lens by whatever technique you prefer. And second is removing that divided lens. Now, in dividing or fragmenting that lens, the ultrasound energy plays a major role. And today there are basically 3 types, but most popularly or commonly used energy modes are longitudinal ultrasound and torsional ultrasound. Now, each of these is very effective. It is both are very safe. So it really, I wouldn't say makes or breaks the deal. So it depends on what your machine has. But you must understand that a longitudinal ultrasound works by moving forward and backward. So it has a tendency to push material, whereas the torsional ultrasound or the ellipsoid ultrasound works from side to side. So it typically doesn't push much. But if you don't use the right kind of parameters, it can sort of get occluded more easily because it is not pushing away the material. So this is one thing we need to understand. Now, the second part, once you have divided the lens, is now how you remove the lens. So lens aspiration, where in most of us use peristaltic pump machines in which there is an aspiration flow rate and there is a vacuum. But if you are using a Venturi system, then there is only one thing, that is vacuum. There is no flow rate and vacuum that work separately. So that is also a very important concept to be understood. But I think most of us, except if you are working on a Vitrector machine, which is by default a Venturi system, or if you're working on a machine like the Stellaris, which also works on the Venturi principle, most other phaco machines are peristaltic in nature today. So like I said, peristaltic and Venturi. What are the characteristics of a peristaltic machine? Because most of us will have access to that. And like you may have read this in your textbooks and you've seen these in the machine cassettes or the machine body, that there is a set of rotor of valves that pinch a tube and cause the flow of fluid, right? So there is one aspiration line that comes from the eye that is sucking fluid, and depending on the speed at which these rollers pinch the tube, you can decide the speed at which they pump. Accordingly, the fluid is drained out of the eye and to the drainage bag in the machine. So this is a basic fundamental. Let's understand the 2 important parameters, flow rate and vacuum. What is the aspiration flow rate? It is the speed at which the fluid moves through the aspiration tubing. That is the aspiration flow rate. That is milliliters ml per minute or cc per minute. So if I say 20 cc per minute, in 1 minute 20 ml of fluid is being removed from the eye through the aspiration tubing. If the same thing, if I say 40 cc per minute, it goes to 40 ml. So much more fluid is being removed from the eye every minute. And like I said, it's measured in ml or cc per minute. What does it do? The flow rate is the rate at which fluid is drawn, which means it also decides the attractability, or what we call the followability in fluidic terminology. So followability is basically how much material is attracted to your phaco tip. So that depends on your IA tip. It could be an IA tip, it could be a phaco tip. How fast the material is attracted depends only and only on your aspiration flow rate in a peristaltic system. All this, what I'm saying, holds true for peristaltic systems. So if I have a high flow rate, I'm drawing nucleus very quickly, which is good because it makes my surgery fast. But what is the downside? What is the downside of having a high flow rate? Can Aditi or Rishabh answer the question?
There are chances of getting PCR.
Absolutely. So yeah, I think 2 things you very rightly pointed out, because things are being sucked up at a very fast rate. There are chances of aspiration of the posterior capsule and probably even more common, iris tissue. If you are going in the periphery to fetch lens material, you are very likely to catch the iris with a high flow rate. Or when your bag is almost empty, because there's so much attraction, the posterior capsule can also come more easily to your phaco tip. So like I said, we discussed this, that the followability or the ability to attract the material to the phaco tip depends on how much flow rate you set. And you can actually control this. If you are, let's say when you are removing the nucleus, the first two pieces, you want faster, so you can have higher flow rate. When you come down to the last piece, or if this patient has a small pupil, or is a diabetic patient, or is a floppy iris patient, you can reduce your flow rate. So you are less like, you will be a little slower, fine, because things will happen little more slowly. But you are safer because you are not pulling in that floppy iris or a small pupil which is already close to your phaco tip. So I think this is why we need to understand what the flow rate does. Somebody who wants to finish my case in 3.5 minutes will have a high flow rate. Somebody like me who likes to take 10 minutes will have a lower flow rate. So here I want to show this clip. This is a very old video, so I pardon the resolution, but this was an experiment we did many years ago just to show. Now here the red box that I've highlighted is the flow aspiration flow rate. This is a very old machine. So now machines are also much better, but what happens is at a 60 cc per minute. That means every minute 60 ml fluid is being drawn. Now what is going to happen when your flow rate is 60? Let's see this. This is a smallish pupil, you can see. And even if you didn't do anything, the iris comes because your flow rate is so high. Doesn't matter what your vacuum is. It's just the flow rate. The same thing, if you drop your flow rate in the same eye to 20, now intentionally the phaco tip is being taken to the iris, but there is no attraction. So if we understand this basic one fact, our surgery will automatically become more controlled. So when your flow rate is low, your attraction is low. So this, where would you use this? Maybe not in every case. Small pupil, floppy iris, subluxated lens. When you happen to have any intraoperative complication, let's say you had a posterior capsule rupture. This is the time when you want to tell your assistant, please reduce on the machine, please drop my flow rate to 20 cc or 25 cc from whatever 35, 40 if you were using that. So be mindful of that. The other very important fluidic parameter in a Venturi machine is vacuum. So in a peristaltic machine. In a peristaltic machine, the vacuum is built up only after the port or the phaco tip, either the phaco or the aspiration tip is blocked or occluded by lens material. Once the port is occluded, what happens is the vacuum will come to whatever level you have preset. So if I don't have any material near my tip and my vacuum is 600, nothing will happen, nothing will be drawn. But once I occlude, then the pump will build up the vacuum to the whatever level I have preset. It could be 300, 400, 500. Now, how do I decide what kind of vacuum I need? Now, vacuum is holding, the power to hold. It is not the speed or the attraction force. It is once you hold it, how well it is going to hold. So then it makes sense that if you have a softer cataract, you don't want too much vacuum because then you will suck up all the lens material. If you have a hard cataract, a very dense cataract, you want vacuum because you want that piece to be held while chopping or while performing your fragment removal. So again, once you understand this, it becomes very easy. So again, occlusion is the obstruction of the phaco tip. And only once the entire phaco tip is occluded by material or viscoelastic, then the vacuum will rise. So one very important thing here I want to bring out, that sometimes what happens is we inject a lot of methyl cellulose. In my beginning days, I used to use 2 syringes per patient. So in my residency, and because I've loaded the eye with methyl cellulose, and I then enter with my phaco probe, and immediately I go to foot position 3. Foot position 3 is one where the ultrasound starts working, and my entire chamber is full of viscoelastic. So if there was no lens material, still nothing has been done, and yet I'm faced with the incision turns white. Can Aditi or Rishabh tell me why would this happen and what would it be called?
Ma'am, the HPMC occludes the phaco tip, and it leads to friction burns of the incision and distorts the incision.
Correct. So excellent. This is called wound site thermal injury or incision burn. Now, when there is a block at the phaco tip, either by nucleus material or by viscoelastic, at the time of occlusion, the pump stops. So no fluid is coming in, right? there is no fluid because the entire tip is blocked. There is no way for the fluid to enter into the phaco tip. So whatever energy you are giving is heat basically. And because there is no cooling because due to lack of fluid, the incision immediately gets burnt. It will turn white. And this will be a very distorted incision, and this can lead to poor sealing. So you might have to suture such an incision. And if you don't, you may be at a risk for even endophthalmitis or leakage from the shallow chamber due to leakage. So I think this is occlusion and vacuum is important to understand. What is negative? What is vacuum? Again, to recap, it is the holding force. So aspiration flow rate is the attraction force, and vacuum is the force with which the machine can hold your material. They are very different. They work together. A high flow rate and high vacuum means things are very effective. A high vacuum, like 500, can go with a low flow rate. That means it comes slowly, but once it comes, it will not be, it is held very well. So that is something we need to understand. They don't have to go hand in hand. And the greater the vacuum, the greater the holding force. And this will be very important in very hard cataracts. Now, what on the other hand is a Venturi system? In Venturi system, if you will see the diagram, your textbooks show the diagram where there is a column of air which causes suction. So there is only one parameter you can set on your machine, and that is the vacuum. So if I set, let's say, 350 millimeters of mercury, at any point of time, whether I have a lens material at the tip or I don't have, it makes no difference. My vacuum is going to be almost in the range of 300 to 350. So what does that mean? That means it is very effective because I will always have good vacuum, good holding. But it is like a double-edged sword. I need to have extremely good control on my foot pedal and on my phaco tip movement because I am more likely to catch things. If I'm closer to an iris and because there is vacuum, there is suction, it will suck up the iris or a posterior capsule. So in Venturi, there is no flow rate and vacuum. You cannot separate the two. If you have a high vacuum, automatically more attraction. If you have a low vacuum, automatically low attraction. So it's just a one parameter system, which is in some cases more faster and more efficient, but it needs exquisite control on your hand and your foot. So typically most of us are more comfortable with peristaltic machines. Now just a brief recap on the foot pedal positions. I'm sure most of you know this and you have tried the foot position. Foot position 1 is only irrigation. Foot position 2 is irrigation and aspiration. And foot position 3 is irrigation, aspiration, as well as delivery of energy. Right? Now, if this is the total travel from foot position 0 to foot position, the bottom of foot position 3, every machine has the capacity to set how much you want in one, how much of the total, if this is 100, how much chunk you want to devote to only irrigation, how much chunk to irrigation and aspiration, and how much to ultrasound. Why would this be important? This is important because let's say most of your foot pedal is dedicated to foot position 1 and 2. When you go to 3, you only have a little travel space. So whether you are in the beginning or in the end, your energy will be almost the same. Whereas if you have a wide travel space, then you can go on a linear control. That means in the beginning, you deliver less energy. And as you hit the bottom, when you really press it, then you will get your full energy. So this is a little more controlled. What should you set? In my practice, I usually like to give maximum space to 2 and 3. So they are 50-50 divided. 1 is just a little space because I want to maintain the chamber. So I want a little bit in 1, but the rest of it is, I would say, almost 40-60 between 2 and 3. And I think how I have learned all this maximum, it's very difficult for you to learn in the day-to-day busy OR. Or in the OT, you don't learn so much with the machine. The best way is maybe on a Sunday or if you have a public holiday, all of you residents or fellows, you can call the machine engineer, the company engineer, who typically the young ones are very happy to come and explain to you. They will show you what everything means, what all you can change and what you cannot, or catch a senior who is really good with understanding the machine. So generally, when I train fellows and when I learned as a fellow, until I did not know the machine, not only theory, but actually what button does what, I wouldn't be comfortable operating. So that is something we all need to understand. Because when you go out and when you are an independent practitioner, your assistant is not going to know what to do with the machine. You are the one who is going to teach them that you press this or you do this. If this error comes, this is what you do. This is what it means. So I think it is worth spending all the time. And here, the company, whatever machine you have, the service engineer, when they come for their routine service, ask them to spend half an hour with you and explain to you what that machine can do. Right? So again, in this foot position 3, which is where all the energy is being given. Now it depends, the foot, you only have a fixed amount of travel that you will have in any foot position. Now it depends on how much energy you set. Like on the left side, if you see, I have preset an energy of 50%. So from 0 to the end, it will only go to 50%. So it's a slow increase if I put it on a linear mode. How is the linear mode? On the phaco machine, it usually shows as an oblique line, and a horizontal line means fixed. That means whether you are here, 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 only 50% all the time will be delivered. Now, if you have maximum energy, that means 100% ultrasound, and you are in a linear mode, then within that same travel, you are going to go from 0 to 100. So the left side obviously is a much more controlled delivery, but it is lower energy. On the right side would be like, for example, in a dense cataract, where you want more energy. And I generally would recommend everybody to use linear control, not fixed or a panel mode, what is called. Linear allows you to slowly increase energy. So that as soon as you go to 3, if 100% energy is given, you are more likely to waste energy, which causes endothelial damage, which can cause wound burns. So if you have a linear control, you are much more comfortable. So this is all about the energy. And which now the irrigation, all this we learned about the attractability, the holding force, and the emulsifying force. Now we need to understand that whenever we set an output, what decides the output? Again, Rishabh or Aditi, I'm sorry, I'm keep asking you questions, but what will decide the output from the eye? What are the factors?
From the aspiration rate and the leakage from the wounds.
Correct. So leakage from the wounds and the aspiration flow rate. These two decide at what speed the output is happening. And depending on what that volume is, you need to match it with your input, which is by the bottle height. Or in some newer machines, it's called intraocular pressure. But basically, the infusion pressure or the bottle height. So if you have more output, high flow rate will need a high bottle height. Low flow rate, you can work with low bottle height. So here again is an example of a wound leak. And you see that this is a sleeve that is compatible with a 2.8 incision. But because the incision is so much larger, and this is what is happening. So the chamber will keep fluctuating and you think it's a bad surgery or the patient is not doing well. But basically, even the side ports can leak. It's not just the main port. So again, make your incision just the right size, for which technique and using a precise knife. That's why, like I said, buying a disposable 50 or 75 rupee knife is sometimes a good idea in giving you much more confidence. Now here I want to show this is a side port. Now typically the side port knife that most of us use is the stab knife, the yellow stab knife. Now there you don't know exactly what is the size, because the bevel, if you see, is tapering and then it becomes broad. So even if it's a 1 millimeter side port, the chopper diameter is much less. So there's a lot of leakage happening. So therefore, in such cases, either you make a smaller incision or you raise your bottle height so that you can compensate for that leakage. Now moving on to the concept of a very, very important parameter in surgery, that is surge. What is it and how does it happen? Surge happens when there is sudden high outflow and the inflow could not match. So the chamber collapses or the chamber fluctuates. That is basically surge, and it's all nothing but fluid imbalance. And here you will see when that happens. Now I want you to notice the vacuum is 700, the flow rate is 25 cc per minute, and the ultrasound is about 40. So this is an extreme level of surge. which may happen, but mostly doesn't happen that frequently anymore because of good machines and good understanding. But what happens? When does this surge happen? It happens when you break occlusion. That means at the end of chopping, after you chop and you took off your phaco probe, or when the fragment that you were eating up just disappears, that's when the surge typically happens, because you had set a high vacuum, let's say 500. So when the tip was occluded, the pump is not working, the peristaltic pump has stopped, and the vacuum has reached 500. Now, as soon as you break the occlusion, the vacuum inside the tubing is still at 500. So it will suck according to the preset vacuum. So it will try to bring in that much amount of fluid. And therefore, we need to understand that the most important factor in creating a surge is not your flow rate, is not your bottle height, but it is your preset vacuum. So whatever, even if I have a high flow rate or a low flow rate, if my vacuum is extremely high, I am very likely to have surge. So the vacuum primarily decides. So now how can we minimize this surge? The most important thing is there are good machines. The tubing compliance, that means the irrigation aspiration tubes in good old days used to be like very, very pliable. Now we have much stiffer tubes, smaller bore tubes. So ideal would be a steel tubing. If you want to really eliminate surge from the system, the ideal method would be to use a steel or a rigid metal tubing. But because we cannot do that, that's not a practical thing. We now have these rubber and all kinds of PVC materials which are very stiff and their wall is thick. So their collapsibility is less. So one is that which the industry or the machines can do. But as surgeons, what should you do? Use modest, I don't say low vacuum, but use only as much as you need. Use modest vacuum. The other very important thing, what we discussed, is that surge happens when there is break of occlusion. Now, if you never have a complete occlusion, that means your vacuum, your tip always had some space through which the fluid keeps coming into the phaco probe. Then you are less likely to have a complete surge. So have a technique where all the time your phaco probe is not completely coring into or completely occluded into the lens material. And don't use too much energy, because too much ultrasound will also cause in sudden disappearing of that fragment. And obviously you want to have a good bottle height, not too much high, but if you have a very low bottle height, or sometimes I have had this, that the pouch ran out of fluid. Nobody noticed. Everybody was so busy operating. The assistant didn't tell me that I've run out of the BSS pouch, and everything collapsed. So these are very small things you must learn to notice every now and then. Just look out of the microscope and take a look at your BSS bottle or BSS pouch. This is one of the commonest things that happens in a day-to-day practice. Small bore tubing, non-compliant, that means more rigid, and small bore phaco tips have now come in, which are all helping us to reduce the surge. Right? Now this is, here you see that the vacuum is about 300, and you see that when the nucleus is being removed, there is no major fluctuation. And this is a slit lamp attachment just to show that the anterior chamber is not fluctuating. That's because the vacuum is modest, and the way we are removing, we are using the chopper to stuff the material so that there is no complete occlusion. At every point, mostly there is some phaco tip which is open, and as long as the fluid keeps flowing, there will never be a sudden fluctuation. And this again is like we saw with the incision, this is a very slow motion video of how technique, whatever machine, whatever tip, whatever ultrasound you are using, how can you minimize surge by improving your technique? And this is what we call carouseling. That means rather than going bevel front, make your bevel side. This works much better with a tip that has a 45-degree angulation. But even if, let's say, if it was a 0 degree, keep your tip little sideways. And when you are removing the lens material, try and make sure. Now you can see here that this is the last fragment going into the eye. And you will see that the chopper is steady. The phaco probe is absolutely steady. I'm not trying to fish here and there. And yet I'm trying to emulsify. Now here you see that the lens material is completely occluded. So this white thing is the lens milk, which you will see only when it's occluded. But most other times, there is some part of the tip which is open. So the fluid aspiration flow rate keeps the material to the tip and it helps in easy removal. So even with a lower vacuum, if you have a good technique where you don't occlude your tip all the time as much as possible, and your flow rate helps your ultrasound and your vacuum to remove this material. So you will see that the chopper is not moving, the phaco tip is not moving, and yet things are happening. It's swirling in, as it were. As you can see, this is what a technique will do, and this is how you can reduce surge. And even in this slow motion, you see that there are no micro fluctuations in the anterior chamber because the phaco tip is very rarely completely occluded. So if you keep hearing a ting, 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 ting sound on your phaco, that means you need to use your chopper to push that material away and reposition it so that there is no complete occlusion. I think this is what the point I wanted to bring about. Now we move on to the actual performing. Once we understand the machine, we have done the good rexis, good hydro, everything. We must understand that lens removal has basic 2 or 3 steps, depending on your technique. For a lot of us, it is 3 steps. One is the sculpting or a trenching, where you are creating a central space. The second is division of the nucleus into pieces. And the third is removal of those divided fragments. Yeah. Why we divide it into, you may not be doing trenching, fine. Then at least division and fragment removal. But what we do need to understand is that each phase has a distinct purpose. Like trenching, you only need ultrasound. You just want to shave off the material. You don't need any holding force. You don't need any vacuum or attraction. Same way, division needs hold because you want to hold the material and divide, chop or do a cracking. So that needs vacuum and it needs energy, it needs good hold. And third is removing the fragment, which needs a good balance of aspiration flow rate, so to attract and keep it at the tip, good vacuum, it depends on how dense the cataract is, and a matching bottle height. So why we need to divide in our mind? Typically, when I learned phaco, there was only one box on my machine, which was, there was there was a pre-phaco and there was a phaco. So in that phaco, everything was done. Then I realized that in sculpting, I want to reduce my vacuum because I don't want to, by chance, while I'm making that trench, I don't want to pull anything. So I reduce my vacuum, I reduce my flow rate, and I have good energy, ultrasound. When I'm dividing, like I said, I want good energy so that I can enter that lens material, and then good vacuum to hold it so that I can chop it. And then while removal, of course, we will discuss again. Now, chop techniques, you can use whatever you like. There are 2 kinds of division. One is divide and conquer, where you make 4 grooves, and then with 2 in the classical divide and conquer had 2 choppers, which would go in a cross manner, and then the nucleus would get divided. So you can still do that, and a lot of us start learning with divide and conquer. But I have given up divide and conquer except in very soft cataracts. Why? Because you have to do so much trenching. So you end up spending so much energy. Your EPT, effective phaco time, or your cumulative energy spent is so high that you end up with corneal edema just because of trenching and trenching and trenching, because you have to trench long and you have to trench deep. So I don't prefer divide and conquer. I like chop techniques more. Now here there are basically 2 groups again. One is a horizontal or a Nagahara chop, which was described by Dr. Nagahara from Japan, where you the chopper, the phaco tip is impaled in the nucleus and the chopper goes beyond the equator and it is brought to the phaco tip in a horizontal manner. The classical chop described this technique with a sharp chopper. But the problem with using a sharp chopper is when you go behind the capsule, you don't know what's happening at the equator, and the sharp chopper tip can actually damage your equatorial capsule. So I like to use a blunt chopper, even for a direct chop. I need good vacuum, but a blunt chopper will do the job as equally well. The other is a stop and chop or vertical chop techniques, where you make a first vertical movement rather than the horizontal movement. This is vertical, and then you separate it out. So again, direct chop and modifications of stop and chop. These are the major chop techniques. Now here is one technique that I want to show that I and all our surgeons, I learned this and all of our surgeons also follow. You will see a small central groove. We don't need to go to the rexis margin or to the equator. A small central deep groove is made. And so you see that it's a very small but a deep trench. What is the end point of a good trenching? That you can see the red glow in the trench. Now you occlude the phaco tip, and you can see here that the vacuum is 340 millimeters of mercury. So you can have vacuum depending on the hardness of the nucleus. You see this chopper, it's more like a modified Sinskey hook. It's a 1 mm tip and a blunt tip, a Sinskey hook type of a chopper, where I'm not worried about the sharpness, the edges being sharp. And the first movement that I make is vertical to initiate a crack. Right? Now I want you to notice that my phaco tip is stable. The phaco tip hand does not move. When the separation happens, it is not a bimanual separation. It is a lateral separation only with one hand through the chopper. You will see that the right hand is absolutely steady. The chopper is coming from the periphery to the center. Right? Same thing is being repeated. You see that you don't need to go to the equator, just create a crack and then divide or separate that crack with small lateral movements and then rotate. Now make as small nuclear fragments as possible. So 4 quadrant is a classical teaching, but you can have 6, you can have 7, you can have 10 pieces. The harder the nucleus, the more number of pieces we would want, so that we restrict the endothelial damage while removing these large bulky pieces. And so what happens is you go around and through that trench, but what is very important here is a vacuum seal. So that's why you need a good vacuum, and that's why you need that you don't move your phaco. Now what happens, and this has happened to me many times, that once I occlude, typically when I move my chopper, both my hands move, and this is when I lose occlusion. And I eat up the material. So I don't have another place to chop also in that area. So that is what I would want to caution. Once you're there, just be dead steady and only move your chopper hand. And this is what I learned from my mentor, step-by-step chop in situ and lateral separation. And here is the animation of what I showed you, the video. Now, if this is the depth of the trench or the sculpt, the chopper is occluded at about junction of upper 1/3 and lower 2/3. And once the chopper is buried, wait for the ting-ting sound to happen. So I think in phaco, along with our hands and feet, our ears also are very important, because auditory feedback, keep a high volume on your machine, and that can also be controlled. In the beginning, keep a higher volume so that whenever there is occlusion, completely the highest vacuum is built, then you put the chop. Then it will be very effective. So wait for the ting-ting sound. It will take few seconds, but don't be in a hurry. And once that happens, create a crack. Then within that crack, you reposition the chopper and slowly separate. I never try to do all the separation at one go, because here and the periphery, we don't notice these zonules. If you do too much lateral separation, you are stressing out the zonules, which you can't see, but which is happening. So therefore, make a crack, and as you can see here, reposition the chopper within the crack and slowly separate from periphery to center. This is the concept of the technique I use, and here again is an example. Now just see that I occlude, and I wait for, you will see here on the bottom right, 698 occlusion. At that time, I also hear a sound. Only then I will take my chopper and make an initial crack. Now I will reposition that chopper deeper and deeper and keep separating out. Right? So this is this technique also, because the chopper is not going to the equator. So therefore, it is safe in small pupils, and you can work within the confines of your rexis margin. You don't really have to go to the equator and be scared of what is happening when you can't see in a small pupil. So this is the technique. It may take 2, 3, 4 times, but don't try to aim separation in one go at a time, is what I would like to say. Here the vacuum is maximum what was available on that machine at that time, which is 650. And again, you see that I am burying. And to bury, you need good power. After that, you bring the chopper. Once the occlusion is achieved, ting ting sound comes, then you start chopping. Otherwise, it will not be effective. And these kind of techniques, almost vertical chop techniques are good even for small pupils, because you are not doing any blind manipulation behind the pupil. You don't need to go to the equator. So you can very effectively divide these even if it is a small pupil. Again, in a very, very leathery cataract, when you do graduate to the level where you want to do a phaco for a very brown cataract, sometimes what will happen that the fibers are so stuck at the bottom that even if you do a division, initially it won't separate. The base plate won't crack. So what you do, first you occlude superficially. So this is what I was saying. When you separate, be careful you don't put too much lateral separation. Now, what you do is you do multiple rounds of chopping or a multi-level chop. Now, this is what I mean. So first you create a crack in a very dense cataract, and then you take your phaco tip and occlude it even deeper, so that now you have more vacuum here in the bottom, and therefore you can easily separate. So this is what we call multi-level chop technique or multi-level occlusion. That means you occlude the phaco tip superficial and then deep, so that you don't need too much separating forces and yet you can divide. Yeah. So this is an example of a really, really brunescent cataract, high myopic eye, and you see that it's very leathery. So one crack was made, and obviously you could not achieve a full separation, good glow. So what you can do now is you re-occlude at a deeper plane and then again complete that separation. But it is extremely important that until you finish the phase of chopping, that means until your fragments are completely divided, don't start removing them. Otherwise, that flower petal thing the whole thing will come in AC, or you will end up causing a posterior capsule rupture. So even if it means occluding 2 times, 3 times, doing 2 rounds of chopping, only once we have divided fragments, then we move to the next phase, which is removing these divided fragments. And this is an ideal situation. You want a lot of fragments, but you don't have to have so many. But I would say at least 6 to 8 is a good idea. Now, phaco energy, when you do remove the cataract, what kind of energy? You may have torsional, you may have longitudinal, not a big deal. What I do like to tell or recommend is using interrupted energy. And again, let me stop and take a breather. So let me ask Aditi or Rishabh, what do you mean by interrupted energy modes?
There is a on and off time. For the phaco power is on for some time and then it is off for a certain time. That is a duty cycle. That is
Correct.
on divided by the total time on
Correct.
time.
Absolutely. So there are, what is the advantage of using interrupted modes?
There's a chance of cooling and
it prevents the complications of associated with damage to the endothelium and posterior capsule, and it also has surgeon has better control over the phacoemulsification. And
how does that happen? How do you think the surgeon will have a better control?
As a beginner surgeon, using interrupted or using duty cycles has helped in having a better control and having the followability as well as aspiration of the nuclear pieces at the iris plane level. If I use the burst, if I use them on continuous mode, it will. It's not my level, ma'am. I feel scared of that mode.
I think your level and it's not my level also. So very well answered, Aditi and Rishabh. So I think what they said is absolutely correct, that when you are in continuous energy, whenever you are in foot position 3, constantly you are giving energy, because of which 2 things happen. One, there is a lot of heat generation, which causes endothelial damage. Second, what happens is, especially in longitudinal ultrasound, because you are continuously giving energy, the ultrasound it keeps pushing chatter, what we call, or pushing of the nuclear material. So if you go to interrupted energy, like they said, there are 2 kinds of modes. One is a pulse mode, where there is a duty cycle. That means 50% time, if you set a duty cycle of, let's say, 100 milliseconds, 50% time energy is being given, 50% time, even if you are in foot position 3, there will be no ultrasound energy delivered. So this helps in the system cooling down and you see less heat-induced damage. But how she said very rightly that it makes my phaco more efficient. Why? Because there is less chatter, there is less repulsion of the lens fragments by that energy, and therefore the flow rate can help to keep the material at the tip while the energy comes in bursts. So one is a pulse mode where classically there is a fixed on and off time. The other is what we call a burst mode, which is a little more refined form of that pulse mode, where you will have a burst of energy, you decide, let's say 100 milliseconds, followed by a burst of off time. You can say that I want 100 milliseconds on time and 100 milliseconds off time, or 20 milliseconds off time. So these are basically all refinements of the same concept of using an interrupted energy. And I think all of us should use interrupted energy as a rule. Continuous energy is really, really very harmful and detrimental, particularly when you use higher amplitude. And when we use energy, most of us are very concerned about what is your total EPT, phaco time, or what is your CDE, cumulated energy. That means how much energy you spent in the eye. This is a measure of that, effective phaco time, how many seconds or how many joules of energy were delivered. But what is equally important, which we don't realize, is how much time you took to deliver that energy. For example, I deliver 10 millijoules of energy. If I distribute them over 1 second versus I distribute them over 3 seconds, what is more friendly to the endothelium? Obviously the 3 seconds, because there is breathing. That same energy was expended over a longer time, versus here it was delivered in a more concentrated time. So slow and steady is typically the best way to go as beginners, as experienced surgeons anyway. Slow doesn't mean you are not it's not efficient. It means you are not super fast. That way you allow the systems to cool down and for the flow rate to bring the material to your phaco tip. Second very important criteria, which most of us never realize, is the plane at which you emulsify. So if this is the endothelium, one is most of us, because we are scared, especially in the last couple of fragments, we bring the phaco tip up and then emulsify. There you are emulsifying close to the cornea. What instead should be done is emulsify away, either at the iris plane or in the capsular bag. And therefore you will be much safer. So posterior plane, conceptually up to the iris is the anterior plane, and iris to the posterior capsule is the posterior plane. So anywhere from iris plane to this is the area where our phaco should be confined, not in the anterior chamber. So I don't like those techniques where the entire nucleus is flipped into the anterior chamber, or if there is you bring it, you prolapse it into the anterior chamber and then phaco it. That is not a good reproducible technique. So here again is again to show, this is a photo slit attached, and you can see for demonstration purposes the same fragment being removed so close to the endothelium versus the same thing being done away from the endothelium. So this, obviously you would feel so much safer doing this. And how can you maintain this? By using moderate flow rate. If you have a very high flow rate, that means a lot of things are being attracted. You are scared that your posterior capsule will get attracted in the last fragment. So therefore, you can drop down your flow rate in the last fragment so that you can still be away from the endothelium and yet not be worried about sucking in the posterior capsule, right? And which is what we call the step down technique. That means that as we emulsify more, as we reach the last fragment here, the parameters, the vacuum and the flow rate are reduced, so that you are less likely to cause any PCR, and yet you can maintain your fragment away from the cornea. So here is an animation. You will see that we started with 300 vacuum. At every 2 to 3 fragments, the vacuum goes down from 300 to 200. The flow rate went from 25 to 20. And in the last fragment, vacuum is 150, flow rate is 18. You don't have to use exactly these parameters, but I wanted to explain the concept that as you remove more nuclear material, particularly in the last 1 or 2 pieces, please consider reducing your flow rate and your vacuum so that you can still be at a posterior plane and not cause a PCR. So here again is this case where you see the vacuum is about 600. And we are trying to house it. You can see that it's at the iris plane. Every time you may not be able to do in the back, but at least in the iris plane. With this kind of a cataract, it's also very important that you keep injecting dispersive viscoelastic. It could be chondroitin sulfate, which is the best dispersive, which coats the endothelium because it has a triple negative charge. Or it could be methyl cellulose, which is also dispersive, but little less effective in coating the endothelium. Whatever you have access to, please inject viscoelastic somewhere midway so that you save the endothelium from heat and mechanical. Like you notice here, this is a fellow surgeon operating and is a little shaky. But at least if you have that endothelial protection, you are not worried about the cornea being white next day. Yeah, and this is what the cornea looked like on day 7, and which is what we all want always. So I think moving on, why do these fluidic parameters, so much I've been talking about flow rate and vacuum, why do they matter? Because we did a lot of studies and we have published about 3 articles where if you have a high flow rate, that means 40 cc per minute, you automatically need high vacuum. And in which case you will see that there is a lot of fluctuation happening on this graph. So this white graph is the actual intraocular pressure within the eye. This is the sensor which was inserted and it is measuring the pressure. So when you have a high flow rate, obviously because the output is more, you need more input. So the pressure can go as high as 80 to 90 millimeters of mercury. Whereas you will see in this clip where the flow rate is 20. And so you need a lower bottle height. There you will see that this white graph doesn't fluctuate so much. And the actual IOP peak is also lower, 60 millimeters. So I think what I want to highlight is that if you use moderate flow rate, 25-ish is fine, and a modest bottle height of 80 to 90 centimeters, you are okay for most cases. You will cause less IOP fluctuations and your corneas will be significantly clearer on day 1, as we found in this study that we published. Yep. Any chat questions or anything before we change segments?
Ma'am, I have a question.
Please.
So, ma'am, in a case of mine where I was emulsifying the last nuclear fragment, the last piece, ma'am,
Yeah.
ma'am, because of the trampolining of the posterior capsule, I had a complication, PCR happened, ma'am. So, how to prevent that?
So yeah, this is very, very crucial, like what we were discussing, that typically it is the last piece when all your PCR and everything will happen, right? So this is when you need to lower your parameters. So that's what I said, step down technique. Bring your flow rate. What flow rate do you normally use on your machine?
Ma'am, I was operating on Pankaj sir's setting. So
see, when he's a maestro. I can't even talk about him because he's the master of surgery, right? So not that you will be one day, but until we are, it's very important that we reduce the flow rate to about 20 or 25 cc per minute. And therefore accordingly bottle can be brought a little down. So I think if you reduce your vacuum, use a vacuum of about 200 and a flow rate of about 20 cc per minute, you will be very less likely to rupture the capsule.
But what about emulsifying it at iris plane after injecting OVD?
Sure, you can. Iris plane is fine. Like I said, posterior plane is anywhere between iris plane to posterior capsule. But anything in the anterior chamber, which normally with me, it always happens by default, reflexly, my hand moves up. If the phaco subconsciously goes a little up, that should not happen. Keep telling yourself that I will be okay, I will be at the iris plane, but what I will do is I will reduce my vacuum and I will reduce my flow rate.
Yes, ma'am. Yes, ma'am.
Yeah. Thank you. So yeah, now we move on to a very sometimes neglected part of phaco, which is irrigation aspiration, coaxial or bimanual, whatever technique you use. Now, this is, I must acknowledge Dr. Paul McCartney, I don't use coaxial IA, but what happens, what I want to highlight here is that in coaxial IA, the only little difficult part is subincisional cortex, which because you have to distort your phaco, your IA probe a little bit, but you can use either. It really depends on what you are comfortable with. So one is coaxial, But like I said, that you distort the sub-incision a little bit. The bimanual I find easy because I have access to 360 degrees of cortex removal. So half of it I remove with aspiration in the left hand, half of it I remove with aspiration in the right hand. Why I also recommend using bimanual, at least if not every day, time and again, because if you have a PCR, you are going to have to do a vitrectomy, which is a bimanual thing. There is no unimanual vitrector. Now, if you have never done, even in a normal case, if I tell you that come on now start doing vitrectomy bimanual, your hands are going to shake because it's not easy. So to cultivate that dexterity also, if you can have access to bimanual IE, at least occasionally keep doing bimanual IE is what I find important, and it helps me do a thorough cleanup. I learned from my mentor, Dr. Alan Crandall. He had published a very nice video on saying that cortex aspiration typically is a very crucial but the most overlooked step in phaco, and I think I agree. Subsequently, Dr. Viraj from our center published this POPs technique, where what we do, as you can see here, the aspiration goes beyond the rexis margin and the cortex is occluded. Now, once that is done, it is brought posterior downwards and side to side movement, so that you can, and then it is the vacuum, then you go on the foot pedal and remove. You don't try to strip off. Radial pull is not your intention. So POPs technique it is called. How do you do that? You will see on the animation, first you occlude. Position your probe just beyond your rexis margin because the bulk is here. Don't try to pull these loose fibers because they can break. So position it right beyond the rexis margin in the bulk of your cortical sheet. Then you occlude. That means press your foot pedal and let your vacuum reach ting-ting sound, occlusion. Then what you do is posterior displacement. You want to remove that entire sheet off the equator. So as you can see on the bottom left, you are, because this is a 2D video, you can't appreciate, but just slightly pull it down. That is posterior displacement. And then you swipe, as you'll see in the swiping actually removes the cortex very effectively. So this looks, it looks like, it looks the same as radial aspiration, but if you see, you occluded, you did this, and then you pulled it to the center. What is the advantage of doing this? I'll show you in this. And you typically end up having more clean capsular bags, and we use this animation. So this is what happens. This is just a toy model with thermocol balls to bring across the point. When you do a radial pull, this artery forceps is, let's say it's the IA probe. So what you're doing is you hold these loose fibers, which you see outside the rexis margin, and you just pull, right? You apply vacuum. So there are chances that in the equator, where you cannot see the fornix of the capsular bag, you will be left behind with some cells, lens epithelial cells, which will cause PCO much faster. On the other hand, if you do a swiping and posterior displacement, what you are doing is gently you are swiping off most of the lens epithelial cells, even from that equatorial fornix region where you could not see. So I think this was one point I wanted to say. Now, in the last segment of this talk, you do a great surgery, everything, but today, your outcome is equal to the refractive outcome or the IOL outcome of surgery. And I just want to touch upon IOL calculation. What you need is good biometry, good formulae, and your personalized A constant. Yep. We all understand that today it's not just keratometry and biometry, axial length. Initially in the SRK2 formula, A plus 0.9, L plus 2.5 K was the formula for the, so where you only needed keratometry and axial length. Now you need so many more parameters: corneal thickness, corneal diameter, anterior chamber depth, lens thickness, because you want to try and estimate the effective lens position or where the lens will actually sit in the capsular bag. And we all understand the components of keratometry and biometry. Most of us have access to the Bausch and Lomb keratometers at our institutes. And what I want to show is these Myers. Now, you can easily measure from in either 5 degree steps or 1 degree, depending on what machine you have. But this is one skill you must learn as a resident. Now I know that there are lots of optometry schools and you may not be getting a chance to do this, but please fight and do whatever, maybe bribe the optometrist off and on and go to this biometry clinic and please learn keratometry. And until very recently, I used to do all my keratometries on my own. And here I want to highlight one thing. If you see the patient's head, it is tilted. Now this will give me a wrong estimation. See this I took a photo from above to show that your head and chin have to be completely well aligned to the instrument, whatever the instrument is. This is how it should be. And the Myers should be not like this, no blurry Myers. The plus and the minus should be very well aligned. Axial length, how do you calculate? You can do contact or immersion ultrasound. Now you also have optical biometers, or even the latest is the swept source OCT. Even if you do a contact, I'm not saying it's a bad technique. What you should remember that the probe in this should be parallel to the fovea or to the center apex of the cornea. This is the wrong position of the ultrasound probe. It should be perpendicular, not parallel, sorry, but perpendicular to the tangential line drawn through the apex of the cornea. Yeah. The more reliable technique is immersion, where you have a little fluid cup. Make sure that you put some cotton in the patient's ears and tell them that water will trickle. Otherwise, they keep moving when you do that. And you should know what good spikes look like. So it has been shown that compared to contact, where there is more chance of indentation, immersion A-scan is a little more reliable. And make sure that whatever, suppose it's a silicon eye or an aphakic eye, change the mode, the technique and the mode on your biometer. Because compression can reduce or increase the axial length by as much as, in a short eye, you can get an IOL power change of up to 3 to 4 diopters. So be very careful with that indentation. And now we have, we may or may not have access to all this, but you should know from exam point of view and when you go out that now you have swept source biometers. A lot of companies make them. You have optical biometers, which have made our lives very simple. But even here, you must look for good Myers. Now, when doing either an automated keratometry, as in this device, or a manual keratometry, where you see those rings, if the rings are irregular, you will make out that this patient has an ocular surface disturbance or an irregular astigmatism. So this is also a very good way of understanding the surface or the cornea of your patient. And this is how you typically capture. Here again, occlude the other eye so that they can give a fixation, because all these automated devices work on the patient's fixation. In terms of formula, typically, I usually recommend now, not SRK2 is obsolete. Please don't use it. And I'm sure most of us don't. SRKT is still okay. But I think the one I like today most, which is free and you can get it online, is the Barrett's universal formula. So please try doing that and you will find that your results improve much more. Again, once you do at least 30-40 cases, you must try and understand what is your consistently, what's your refraction coming. And that will help you to personalize your A constant. And this is the Barrett's formula that I just alluded to. We now have a very good AI-based formula, the Hill RBF calculator. And like I said, assessing the regularity of your cornea will also need more diagnostics like topographers and all. So I think that brings me to the end of my talk, and I'm very happy before we go on to the quiz question. Any suggestions, comments, questions?
Dr. Vaishali, it's a wonderful talk.
Thank you, sir.
I learned a lot from this talk.
That's very kind of you.
Mm-hmm.
So I think because we are all, I think you are all also waiting for dinner. Let's move on to the quiz questions. And I'm going to put up the first quiz questions. And I don't know how we will judge this, but we are going to have, I think, 15 seconds for voting.
Yes.
And I think let's run through the quiz questions and then we'll discuss. So 2 questions in this first slide. Name the famous ophthalmologist that you see here on the slide, and also name the invention that he made which has changed the face of ophthalmology. So I see, correct. So I think we have 1, 2, 3, 4, 5, 6, 7, 8 responses, and all of them are correct. And for those who may not have yet replied, the correct answer is Charles Kellman from USA, who invented phacoemulsification, and I think we are also grateful to him. Just a little trivia. Charles Kellman was also a very great saxophone player. He was a trained pilot. And during his dental appointment, when he was getting a scaling, he realized that if dentists can use a burr, why not we use something like this? So yeah, that I find that this is very important to know. And I didn't put any technical questions today in the quiz because when we move forward, it's very important to be grateful and to acknowledge and understand who made it possible for us to do all these modern things. So that, I think that was my idea. Same way, the next question now, please be ready to vote. Name this famous ophthalmologist, and again the invention that changed the face of how we practice today. I see good responses coming in. Yeah, so I think most of you got it right. This is Sir Harold Ridley, who implanted the first IOL in 1949. And I think you must have heard this anecdote, but this whole idea came from a fact of a shrapnel of an aircraft. And he realized that if that can remain sterile, why not put this in the eye? And the first patient who actually got an IOL lost his eye, and they had to actually remove the IOL. So that's a separate part, but that helped us to reach where we are today. And I think that's it from my side.
Thank you, Dr. Vaishali. This has been wonderful, Kaksha, by Dr. Vaishali. Mastering phaco is a vast topic and lifelong learning, and it is impossible to cover everything, but it was a very well explained and in a very comprehensive and crisp presentation. Thank you all resident, ROS executive, our respected teacher, and Dr. Vaishali for the excellent teaching. We look forward to the next class in the coming weeks. Please subscribe ROS YouTube channel. Thank you. Good night. Good night, Vaishali.
Thank you. Thank you, everybody. Good night.
Thank you, ma'am.
Thank you.
Yeah.